Well, it's great to be back here with all of you. I think this is a great lecture to give again, just because, even several years into my practice, it's something that I struggle with every day because finding the right patient for every surgery that we indicate, I think, is probably one of the most challenging things about spine surgery. And so really more questions than answers here in this talk, but considerations I want you guys all to have moving forward as you begin your career. So we'll review some of the literature about MIS or open. Some of these questions are very focused, and how they relate to your practice, I think, is really dependent on how you've been taught to do these techniques. I think a good surgeon can do any technique well, but you have to make sure that you're really taking the time to do things appropriately and asking the appropriate questions of the technique that you're using. And so, just wanted to, bring this up. This was looking at TLIF. It's a very straightforward question to answer, MIS, TLIF versus open. But these are done very differently. One of the things that we know, less blood loss, shorter length of stay, that's pretty consistent across many studies that have looked at this question. Less radiation exposure in open surgery, especially for those placing free-handed screws. But when we look at the final follow-up down the road, there's really not a huge difference. The main gain, I think, is in that early postoperative period when you're getting patients out of the hospital more quickly, when they have less pain. That is a significant difference in terms of quality of life, as well as the cost to your hospital. So these are important questions to ask. And again, this is just going through all those studies and showing very modest difference in terms of the actual outcomes measures at the end of the study period. And so, all of these questions are still out there. Even in our panel here, each of us will tell you that one technique is better than the other, but the way that we do them is very different. So you have to look at, long-term fusion rates. Are these people using bone morphogenic proteins in their, fusion versus, I know here, Jens and I do a lot of open IDOs or TLIFs, and, we're not using much product at all and getting very good fusion rates. So again, I think that's largely technique-based. In some of these studies, you're not really comparing apples to apples, and you have to look at all these studies with a grain of salt because there is bias in all of them. Laminectomy versus laminotomy. Again, we talked a little bit earlier about doing a midline sparing laminotomy as opposed to some people. I know a lot of people out in the community, we have fellows that come here that have only done, more traditional radical laminectomy. I think in terms of looking at the patients for people that have undergone both, there's pretty clear evidence to say that a laminotomy has some benefits in terms of, especially if you're the one who's having to revise those cases, really maintaining some of those landmarks. I know in my practice is very helpful if they do need to be converted to a fusion further down the road. I want to maintain as much anatomy as possible, whereas you're getting an appropriate decompression. And doing midline sparing, for me in my hands, allows me to go actually a little bit wider in terms of decompressing the lateral recess, as well as keeping that midline intact, keeping the ligaments and the inner spinous space intact. I do think is very important and leads to better function in patients. So this is a case of mine, 61-year-old back and leg pain. He's got this isthmic spondylolisthesis at 3-4. You can see not a whole lot of central stenosis. Foraminal stenosis is his main complaint, as well as back pain. This is kind of a unicorn case. If everybody that walked into your clinic was this patient, I did through a prone lateral approach. Patient was very, very happy, but this is an incredibly small percentage of people that will come through the door. And I think in the right patient, doing an MIS approach for him worked very well. He's been very happy, but again, what are the outcomes that you really need to be focused on? In this patient, absolutely in my hands, they're getting an MIS approach and getting out of the door quickly, and I think those are meaningful to the patient. So why are we still doing open surgery? The pretty major in I think across the board, all of these can be argued. There's some exceptions to all of these, but when we're doing tumor surgeries, and specifically I'm talking about separation surgery, being able to see the neural elements, making sure that you're removing that tumor. And if this patient has a metastatic tumor, they're going for radiation surgery. If you can get that tumor away from the neural elements, it allows them to use a higher dose of radiation, really targeted, and have a more effective radiation treatment course. Major deformity cases, we have Neil Anand here, who does some pretty amazing MIS deformity. Really takes a lot of work on the anterior column if you're going to do a percutaneous posterior treatment for those. In my hands, I tend to do most of my larger deformity cases open. Making sure you're not dealing with ankylosis. I think a lot of failures are just unrecognized ankylosis of the facet joints, and trying to do an MIS procedure is just not going to be a good outcome. And then complex revisions as well. So I think this was a case that I had recently. So a 67-year-old woman, and I'd want to open this up for discussion on the panel because I think this is something we all treat differently, and this is probably going to be the most common patient that comes into your clinic. So very active lady, no real health problems, has both low back and leg pain, really loves to be outdoors. She told me, after her surgery, she did 44-mile ride on her e-bike and was very happy. But little bit of a spondy there at 5'1". She's got some transitional anatomy at the bottom, but pretty well-preserved disc spaces. You can see here that's 4'5" in kind of the bottom left, 5'1". Not terrible central stenosis, has significant complaints of claudication. So, and we got a CT on her as well. Some pretty advanced facet arthropathy with really well-preserved, anterior, really not a lot of disc collapse there. So Jens, the one who puts everyone else on the spot, what are you doing here?
So I'm going to be very clear. I'm going to, if this is a physically active young patient, not fuse this patient and give an interlaminar stabilization with a nice lateral recess stenosis as a day surgery and send her out. And I'll quote a 15% failure rate over 5 years. And I'm going to pass the microphone on to Dr. Lord, and then I'm going to take the microphone from her to Dr. Skaggs, and then run down the rest, and we'll all do rapid fire. What would we do and why?
Yeah.
I'd really quantify how much of her pain and specifically disability is due to back pain versus
50-50.
50-50? I talked to her about it. Yeah. I would say, we can do what Dr. Chapman recommended. You may still have that back pain if that's enough to buy you a couple years. Some people just want to have one spine surgery, and that's okay, in which case I would offer a fusion.
Great.
Dr. Skaggs is going to you're the co-director. You're responsible for your young attendings. What are you going to tell them? Your young attending is coming to you. Dr. Skaggs, what should I do?
I honestly should not responsibly comment on a 67-year-old.
It's a 6-year-old. No.
So, when you look at the CT and the MRI, it looks like the CT scan kind of makes it look like there's almost an autofusion at 5'1", and then when you look at 4'5", it's like she has adjacent segment disease from the autofusion at 5'1". With those big juicy facet joints at 4'5". So it's like she has already proven that she is susceptible to adjacent segment disease from a fusion. Unfortunately, I feel like the best outcome is going to be a fusion in this patient, because she's basically got a fusion and she needs to treat the adjacent segment disease in addition to the so 4 to 1.
Fusion. That's beautiful.
Fusion. So you want to enter her in the annuity program of the Sansur retirement No, but seriously, MIS open. What would you do? ALIF.
So with a very tall disk space at both levels, I think that getting a solid arthrodesis might be difficult, and a front back might be indicated.
I'll start with a foraminotomy, and then see how things go.
What about you, Kai?
I'm definitely would not do a fusion right away. I'm more of a decompression person.
And Rod?
I mean, this is really easy, Amir. Everybody should know the answer. Artificial disc, one level, ADR.
Which
Why
level?
would you want a fuser? I mean,
Which level?
reason. Come on, you
CT.
guys. This is a home run. She would do great with an ADR. Yeah, you nice distracted open. She'll be very happy.
So,
You know,
I
she'll
love this
be
case
miserable
because
if you cut open her back muscles, she'll be so unhappy with you, Amir.
I love this case because
Yeah.
I think these are all correct answers.
Honestly,
and
ADR is a great option. And Jens, you're the one I can blame for this because you put that in my head like a long time ago. ADR is a great. People just don't think about it. I mean, this is a perfect case.
so the one thing, I mean, ADR for her, seeing she's kind of got that spondy at 5'1", I would be a little, trepid there. But all of those answers I think are appropriate. And, as Dr. Lord mentioned, the most important part for me is the discussion. Absolutely for these patients, I have the discussion as to, we can do a smaller surgery and it may not work. And, without question, that 15% failure rate that Dr. Chapman just mentioned, there is a percentage of people, they come back about 9 months on the dot with recurrence of stenosis or back pain. And as long as you have that very clear discussion with them, they're really not upset. They know that, there may be more surgery down the road. And, looking at, we'll look at a quick study here in a second, but going from a decompression to a fusion as opposed to starting with fusion and dealing with this adjacent segment disease, I have a lot of patients that come in and they want the lesser option. And as long as you're very clear, and I do have patients that say, I don't want to have to deal with anything else. I want one surgery and I want it to be definitive. I would probably push them towards a fusion. This lady actually, very happy. Her leg pain is gone. She still has a lot of back pain. And she's like, I know you told me I would, but now what do I do about my back pain? So, without question, she still does not want a fusion, but, I think these are very challenging patients. There's going to be lots of ways to deal with them. And the communication is far and away the most important piece. So we talked about all those options. This is a recent study out of, European Spine Journal, 5 RCTs, 2 prospective studies, a 2-year follow-up. They say there's no difference between decompression and fusion. If this study was done in the United States, they would say that fusion is better. There's very clearly a bias from where you're getting your surgery done and how these outcome measures are really analyzed. So again, when you pull these data together, we know that there are certain patients that will not do well with the decompression only. It's always going to be a challenging discussion, but there's data to support it either way. So something, even as we redo these studies with big meta-analyses, the answer is still not very clear in my opinion. Just a few points here as we move forward. These are a couple MIS TLIFs that I had to revise with pretty bad subsidence using expandable technology. And I think MIS TLIF can be a great surgery, but if you're not preserving that end plate and getting the height that the device was designed for, then that's going to be a patient that doesn't do well. Indirect decompression, is a very real thing that you just have to be using the techniques appropriately. This is a great study where out of Japan, where they were able to get direct post-op MRI, 6 month, 1 year, and 2 year. I don't know that anywhere would be able to get this funded here in the United States, but over time, seeing continued improvement in terms of indirect decompression. And absolutely, if you're having good techniques, indirect decompression can be very effective. You just need to make sure that you're choosing the right patients. And again, if you do find that you're having subsidence, for those of you doing, for instance, this is an MIS TLIF approach, switching from something that's more of a straight placement of the cage to something on the apophyseal ring, you can salvage that procedure and get the indirect decompression you're looking for. You just have to be very mindful that you're not violating the end plates. And even if you do, you have a bailout plan to where you can address that and get appropriate results. You may want to do more direct decompression if you're not very happy with your end plates intraoperatively. So just things to keep in mind. We talked about those, post-op radiculitis. I don't do a ton of MIS TLIF. Again, I really like my outcomes with open IDO. In terms of what we're doing, it's a little bit more work, but I've been very happy with my outcomes. I do plenty of lateral and ALIF with percutaneous fixation, and for me, that's why this is such a challenging question, is because I think there's a best surgery for every individual patient, and if you have all of these techniques in your armamentarium, then you're able to cater your surgical plan to each person individually. Again, just something to be aware of. I think for some people, the technique of MIS TLIF is limited in terms of the preparation of the disc space and the limitation in terms of posterior lateral fusion. So I think more people are using off-label bone promoting, biologics, and you are going to see radiculitis. I don't do a ton of these, but in MIS TLIF patients, the radiculitis is a very real thing, something to have a discussion with your patient with ahead of time. Another case that I saw come in, MIS procedure at both levels. There was a post-op radiculitis. Was this because of BMP? I thought that possibly this screw here was in the foramen. The surgeon kind of told this lady that everything looks great. It's just kind of, you're going to have to live with it. So I basically just redirected that screw, and she was very happy with her outcomes. So again, this would never happen in an open procedure because you're looking at that nerve root, knowing that if you do use an MIS technique, you need to be able to be aware of the potential complications and have a very keen eye for them if they may arise.
Question?
Please.
If that screw was stimulated, the surgeon should have picked it up at the time they put it in.
Absolutely.
And do you think that most people routinely stimulate lumbar screws when doing MIS? Or should they?
Good question. I typically don't, but I always have EMG available. If there's any question on my imaging, I have it readily available to, if anything looks bad, I'll stimulate it. Especially using navigation, I think, I'm pretty secure. If there's small pedicles, absolutely very low threshold. Question?
So I want to ask you a question and ask my neighbor to my right here, Dr. Lord, to weigh in on that in terms of complications. So MIS offers this potential to be like a superstar with super small soft tissue exposures, but there are these nagging few but catastrophic complications. So I'll start with Liz maybe. What's your advice to young surgeons who are entering a competitive marketplace? They have to market themselves as MIS as to adopting new technologies. Let's just say a prone position, lateral procedure to kind of be cool and same setting, do a surgery when in fact we all know that 100 to 1,000 patients can have an absolutely catastrophic complication.
Yeah, I think that's a really good question. And, like I said in the talk, fear is holding, I think, a number of people back from trying those things. People are very reticent to do things that they're not well trained on, which is, as well they should be. But that being said, we do need to move the ball forward in terms of spine surgery techniques. And if everyone just did the things they were taught, we'd all still be doing only open surgery, no interbodies, et cetera. So in terms of adopting new techniques, once you're outside of training, I'd recommend 1, assessing what you're familiar with, 2, doing a ton of courses. I go to ESMIS every year. I did the ESMIS Traveling Fellowship, plug for that. Plenty of industry courses are offered on these. Take advantage of these opportunities like this course to really understand the anatomy when there's no time pressure whatsoever. Understand the pitfalls, understand the anatomy, and then prepare yourself mentally for these things happening. It's also supportive to have essentially a more senior surgeon who's doing some of this stuff, so that if you are the younger person and get into trouble, they can at least back you up and say that, oh, they're doing it safely, they're doing the best they could, and these things just happen. And, understand yourself and your abilities. Don't, if you've never done a prone lateral, don't do it your first week of, attending hood, having never done it. Build a foundation of safety and a good reputation for yourself. And then once you have that, get the training and you can try new things. That's how we advance the field.
So, Mary, any thoughts from your end? Again, you're in a more senior stage of your career, so putting on these new cool technologies, yet we all know that, for instance, with far lateral surgeries, there have been bowel perforations. We've never had those before. We've had ureteral tears with hydroretroperitoneum. We've had MIS decompressions with endoscopic surgery. So a patient had a hydrothorax, hydroabdomen.
Tension hydrothorax.
Tension hydrothorax. Yes, never heard of that before. So how do you weigh the rare but potentially catastrophic complications versus the relative benefits of MIS surgery?
Yeah, again, this is something I struggle with all the time. I think, again, when you have the patient that does exceedingly well, like the first one I showed was prone lateral case. And, for me, having trained here with Rod, we did traditional lateral, then bringing in navigation, then, now prone techniques. It's been kind of a progression for me step by step. So when you're adding something in, it's not that scary because it's a small change from something you're comfortable with. Whereas jumping straight into a technique that's very unfamiliar, like prone lateral, having never done any lateral before, again, as Liz mentioned, you want to make sure that you're learning from people that are more experienced than you, being comfortable on a cadaver. Because there are real benefits when you see those patients do very well, that sticks in your mind until you have that major complication, and that will also stick in your mind. But it's always going to be a push-pull between those two, very dichotomous outcomes.
And I just want to add one thing also, not everything is for everybody. Like in my mind, some of this stuff, because of the complication profile, this is for people who can be like, I am meticulous. I am meticulous. If it's not right, if it doesn't feel right, I'm going to bail and not do it. It's not for people who are just going to like, oh, this is, the case, I'm doing it, I'm pushing through. You need to be absolutely meticulous and willing to bail out if there's any sign of a problem.
Yeah, I think it's fair to say that not every new technology will be adopted. There were years ago, they used to put what I called the up the butt screw. They thought it was good to fuse S1L5 by putting a screw up the butt. Like, how insane was that? But everyone at the time was going, this is the new way.
All great points. I'll just kind of go through this one case here. This was a lady who has had various procedures, as we can see. Standalone lateral. The surgeon recommended doing a second standalone lateral at the level above in order to treat her recurrent pain. Again, MIS surgery is great, but at a certain point, you really just have to kind of bite the bullet and, give the patient something more definitive. And this lady did very well with a deformity correction. So thank you.
Awesome.